My name is Erica G., and I'm a senior resident at MGH and future regional and acute pain fellow at Stanford. This presentation will provide an overview of upper extremity nerve blocks. As we review the brachial plexus, we will introduce the anatomy and indications for the four most commonly used upper extremity blocks: the interscalene, supraclavicular, infraclavicular, and axillary nerve blocks. The nerve blocks of the upper extremity differ in their targets along the brachial plexus, with the interscalene nerve block as the most proximal and the axillary block as the most distal target. As you can see in the picture above, the coverage of the block decreases as the target moves more distal. Next, we will review the anatomy of the brachial plexus from proximal to distal, beginning with the nerve roots. The nerve roots of the brachial plexus originate from levels C5 through T1. In the figure to the right, the red arrows highlight the nerve roots as they exit the spinal cord. Figures 1A and 1B above demonstrate the sensation to the arm that each nerve root is responsible for, with the top photo, or figure 1A, showing the dermatomes of the palmar side, and figure 1B below showing the dermatomes of the dorsal side. As you can see, C5 through T1 cover most of the arm, with the exception of the medial upper arm, which is covered by T2. T2 can be blocked separately by targeting the intercostobrachial nerve. As the nerve roots exit the spinal cord, they give off a few early branches. The first branch is the dorsal scapular nerve, which branches off of C5. After this nerve exits the brachial plexus, it pierces the middle scalene muscle and continues deep to provide motor innervation to three rhomboid muscles: rhomboid major, rhomboid minor, and levator scapula. The net effect of these muscles is to elevate the scapula and pull the scapula medially towards the spine. The next branch from the nerve roots is the long thoracic nerve, which branches from the ventral rami of C5, C6, and C7. The nerve descends posterior to the nerve roots and courses along the chest wall to supply motor innervation to the serratus anterior muscle. The serratus anterior muscle is responsible for protraction and upward rotation of the scapula. Injury or entrapment of either the dorsal scapular nerve or the long thoracic nerve can result in destabilization of the scapula, also known as wing scapula deformity, which is shown in the picture above. C5 also contributes an anterior branch to the phrenic nerve, which is made up of C3, C4, and C5. The phrenic nerve can be found along the anterior scalene muscle, as you can see in the figure above, designated by the green arrow. The ventral rami of C5 and C6 also give off anterior branches that form the subclavius nerve. This nerve continues on to supply the subclavian muscle, highlighted in green in the picture to the right. This muscle is responsible for stabilizing the clavicle. Here, at the level of the nerve roots, we will pause to talk about the interscalene nerve block. This block targets the roots of C5, C6, and C7, as designated in the figure to the left by the yellow line. In the figure to the right, the blue arrows point to the yellow roots of C5, 6, and 7 as they course between the anterior and middle scalene muscles, which are highlighted in green. The indications for interscalene nerve blocks include surgery to the shoulder and proximal humerus. This block can also be used for clavicle surgery when supplemented with a block of the superficial cervical plexus. The supraclavicular nerve, which arises from C3 and C4 branches of the superficial cervical plexus, is responsible for the area highlighted in yellow in the figure above, which would be necessary to cover for surgery of the clavicle or trapezius. The figure to the right shows sensory coverage of the interscalene block in red, with the smaller picture demonstrating bone coverage of the block. As you can see, this block thoroughly covers skin of the shoulder and upper arm. As we discussed in the previous slide, coverage of the skin overlying the trapezius and lower neck can be included with a supplementary block to the superficial cervical plexus. It is important to note that this block does not include C8 and T1, and will therefore spare the ulnar dermatomes and osteotomes, making this block less ideal for hand surgery. Here we will briefly touch on the ultrasound anatomy of this block. In the picture above, you can see the roots of C5, C6, and C7. C6 will often present as two separate roots, one on top of the other. The dorsal scapular nerve, responsible for innervating the rhomboids, can sometimes be seen as it courses through the middle scalene muscle. It is important to avoid injury to this nerve with your needle, as it heads towards the nerve roots when performing the block. The superficial cervical plexus can be found superficial to the nerve roots, near the tip of the sternocleidomastoid. The phrenic nerve can be found anterior to the nerve roots, and underneath the sternocleidomastoid muscle. The proximity of this nerve to the location of the block explains the high likelihood of having diaphragm paralysis with the interscalene nerve block. In summary, the interscalene nerve block is ideal for surgery of the upper arm and shoulder. Due to the proximity of the phrenic nerve, it is important to use caution when performing this block on a patient with chronic obstructive pulmonary disease. Other risks of this block include local anesthetic toxicity, total spinal, Horner syndrome, and C5 nerve root injury, which can result from inadvertent injection into the nerve root. Returning to the brachial plexus, as we move distally, the roots will converge into three trunks: the upper trunk, the middle trunk, and the lower trunk. In the picture to the right, the blue arrow identifies the trunks of the brachial plexus, which lay lateral to the roots. The upper trunk gives rise to the suprascapular nerve, which contains innervation from C5 and C6. This nerve contains both sensory and motor innervation. It provides sensation to the acromioclavicular joint as well as the glenohumeral joint of the shoulder, making it important for any blocks meant to provide pain relief for shoulder surgery. Its sensory coverage is highlighted in purple in the figure to the right. Its motor fibers innervate the supraspinatus and the infraspinatus muscles. Here, at the level of the trunks, we will pause to talk about the supraclavicular block, also known as the spinal of the arm. The supraclavicular block is ideal for surgeries from the mid-humerus of the arm through the hand. Coverage of this block includes the lateral surface of the shoulder, covered by the axillary nerve, shown in pink on the diagram to the right. However, can sometimes miss other parts of the shoulder that are covered by the suprascapular nerve and the supraclavicular nerve, both of which would be reliably covered with an interscalene nerve block. This block also includes the ulnar nerve distribution, although sparing can still occur. The supraclavicular block will exclude the medial upper arm covered by T2, or the intercostal brachial nerve, which would need to be covered with a separate block. This is important for tourniquet pain. Coverage of this block includes the lateral surface of the shoulder, covered by the axillary nerve, which is shown in pink on the diagram to the right. However, this block can sometimes miss other parts of the shoulder that are covered by the suprascapular nerve and the supraclavicular nerve, both of which would be reliably covered with an interscalene nerve block. This block also includes the ulnar nerve distribution, although sparing can still occur. The supraclavicular block will exclude the medial upper arm covered by T2, or the intercostal brachial nerve, which would need to be covered by a separate block. This is important for tourniquet pain. Here you can see the three trunks clustered next to the subclavian artery and above the first rib. Notably, the pleura is visible in the frame, reflecting the potential risk of pneumothorax with this block. Of note, the lower trunk is the most medial and closest to the rib and pleura, which is why this trunk can sometimes be inadvertently spared. In summary, the supraclavicular block, also known as the spinal of the arm, is ideal for surgery of the mid-humerus through the hand. Ulnar sparing is less common but can still occur. As with the interscalene block, it is important to use caution when performing this block on a patient with COPD due to proximity of the pleura and risk of pneumothorax. Because this is a relatively deep block, standard rules for anticoagulation still apply. Risks with this block include Horner syndrome, phrenic nerve palsy, and ipsilateral laryngeal nerve block, which can result in a hoarse voice. As we move distally in the brachial plexus, the trunks give rise to 6 divisions. 3 anterior divisions give rise to the upper extremity flexors, and 3 posterior divisions give rise to upper extremity extensors. The 6 divisions converge to form 3 cords, the lateral, posterior, and medial cords, which are named based on their location with respect to the axillary artery. Here, the cords give off some notable branches to nearby muscles. The lateral and medial pectoral nerves branch off of their respective cords at this point in the plexus to supply pec major and pec minor muscles. The posterior cord gives rise to three nerves: the thoracodorsal nerve, upper subscapularis, and lower subscapularis. Here, at the level of the cords, we will pause to talk about the infraclavicular nerve block. In the picture above, you can see that at this point in the brachial plexus, the cords are found surrounding the axillary artery. The indications for an infraclavicular nerve block include upper extremity surgery from the mid-humerus through the hand. This block will cover some of the axillary nerve distribution of the shoulder, as reflected by the pink color above. It also includes the ulnar nerve and has less risk of ulnar sparing than the supraclavicular block. Again, the medial upper arm, covered by the intercostobrachial nerve, is excluded. In the picture to the left, you can see the cords situated around the axillary artery, located deep below the pectoral muscles. The cords will rotate around the artery as you scan laterally. The picture to the right shows variations in anatomy, showing the multiple positions where different cords can be found. In summary, the infraclavicular block is an excellent choice for surgery of the upper arm through the hand. It is ideal for catheter placement and has less risk of pneumothorax. However, this block can be technically difficult in obese patients, as the structures can be deep and difficult to visualize. As we move to the end of the brachial plexus, the cords give way to multiple terminal branches. The lateral cord gives off a branch that forms the musculocutaneous nerve, which provides sensation to the lateral forearm. The medial cord gives off two cutaneous branches to the medial arm: the medial cutaneous nerve of the arm and the medial cutaneous nerve of the forearm. These nerves are also called the medial brachial cutaneous and the medial antebrachial cutaneous nerves. After giving off these branches, the medial cord continues on as the ulnar nerve. The posterior cord divides into two terminal branches: the axillary nerve, which supplies the lateral shoulder, and the radial nerve. And finally, the median nerve is formed by two branches coming from the lateral and median cords. These branches are known as the medial root of the median nerve and the lateral root of the median nerve. The axillary nerve block takes place here at the level of the terminal branches of the brachial plexus. This block is suitable for surgeries of the elbow, forearm, and hand. You might consider this type of block in somebody with difficult anatomy, respiratory comorbidities that would make avoiding the phrenic nerve blockade desirable, and patients on anticoagulation, as this site is easily compressible. This block provides coverage of the upper extremity below the shoulder. Of note, the axillary nerve, which gives sensation to the lateral shoulder, is not covered by the axillary block. We will pause here to briefly touch on each of the terminal branches, beginning with the purely sensory nerves of the arm. The first branch is the musculocutaneous nerve, which not only provides sensory innervation to the lateral forearm, but is also responsible for sensory innervation to the humerus. The other purely sensory nerves of the arm are the medial cutaneous nerve of the arm and the medial cutaneous nerve of the forearm, which branch off the medial cord and provide a large degree of sensory innervation to the medial part of the upper extremity. The remaining three terminal branches provide both sensory and motor innervation to the upper extremity. These branches are the median, radial, and ulnar nerves. The radial nerve, which receives innervation from C5 through T1, contains multiple sensory branches that provide sensation to the posterior arm and lateral forearm, as demonstrated in the picture on the right. It provides motor innervation to the muscles of the posterior arm and forearm that are responsible for extension at the elbow, wrist, and fingers. The median nerve supplies cutaneous branches to the lateral palm and lateral fingers and provides motor innervation to the flexor and pronator muscles of the forearm, as well as the thenar muscles of the hand. The ulnar nerve, which receives fibers from only C8 and T1, provides sensory innervation to the medial 1.5 fingers and associated palmar areas. It supplies motor innervation to the forearm muscles that are not covered by the median nerve, as well as the majority of the intrinsic muscles of the hand. In the ultrasound image here, you can see the terminal branches as they are clustered around the axillary artery, with the conjoint tendon in view just below the radial nerve. You can see here that the musculocutaneous nerve is separate and must be blocked with its own injection. Depending on your location in the axilla and depending on patient anatomy, the musculocutaneous nerve of the arm, the musculocutaneous nerve of the forearm, and the median or lateral roots of the median nerve can sometimes be visualized in this space. In summary, the axillary block is another useful block for surgeries of the upper arm through the hand and can be considered in patients with difficult anatomy or patients on anticoagulation, since it is a compressible space. The musculocutaneous nerve must be covered with a separate injection. This area has many venous structures, so it is important to aspirate frequently to avoid local anesthetic toxicity. This concludes our overview of the brachial plexus and upper extremity nerve blocks.